Good afternoon, everyone. We will get started in just a few moments. If you are a committee member, if you would please put your name in the chat so we can make sure we capture correct meeting attendance. We are just waiting for a few more folks to join, so bear with us just a few minutes. Thank you. Again, thank you for joining the MAC meeting this afternoon. We will get started in just a few minutes. If you are a committee member, if you would please put your name in the chat so we can capture meeting attendance. If you are a committee member who's on the phone, please unmute yourself to let us know that you are here. Thank you. We should be getting started in just a few minutes.
All right. Sharon, hi, it's Jessie. How are we doing on quorum?
We have a quorum, so you can definitely get started. Thanks, Jessie.
Great. Well, welcome everyone to the July Medicaid Advisory Committee. I know it's almost August, but we're still in July, so I hope everyone is doing well and having a healthy, safe summer. And I'm Jessie Mandel. I'm with the organization Voices for Utah Children, and I'm also the chair of the Medicaid Advisory Committee. So great to see everyone that's on camera and the friendly faces in the chat. So we're going to just jump right in with approval for the June 2020 minutes. And I know we have some new committee members joining us. We'll be introducing you all shortly, but first let's just take care of approving the minutes. Would any committee members like to have reviewed them or like to make a motion to approve the minutes?
So if nobody else has any changes, Jessie, I would make a motion that we approve the minutes as written.
Happy to second that.
Great. Thanks, Michael and Alan. Great. All right. Next up is a thank you for Dr. Cosgrove. You have been the chair. You're the immediate past chair of the MAC, and you've been just phenomenal member of the MAC. It's been an honor to be on the committee with you, and I'm sad to see you leave, but I hope you will not go far. You know where to find me, but it's been truly an honor to get to work with you on the committee and appreciate all you did as chair and just all the work you've done. So thank you so much for being on the MAC for this 6 years. For 6 years. Like I've counted every. Great. All right. Well, thank you so much. And on to welcoming new members. We have several new members. We have, I'm going to start actually with Davis Moore, who will be filling the pharmacy seat. And Davis Moore is he's worked with Medicaid services at the Redwood and Greenwood clinics. And he will be the representative for the pharmacies. And we're very excited to have you on the committee. So thank you, Davis Moore. Are you here? And if you so, please feel free to come on and introduce yourself.
I am sorry, I'm kind of crooked. I'm out of town, so but I am happy to be here. Thank you for letting me serve here in the committee, and I'm happy to fill any jobs that you need to have done.
Great. Well, we're really excited to have you here, and I only just now sent you a welcome email with just a little bit more background about the bylaws, but hope you will feel free to participate, and we're excited to have your perspective on the committee. So thanks.
Thank you.
Next up, I'm going to welcome Rachel Craig, who is no stranger to this committee, but very excited to have you filling the role for the association, or for community health clinics, community health centers, excuse me. So Rachel is the legislative coordinator at the Association for Utah Community Health, or OUCH. And she, of course, has been regularly attending the MAC meetings. She tracks federal and state legislation, and her perspective is going to just be really fantastic. So we're really excited to have you on. Rachel, do you want to say any words as you jump in?
You covered most of it, Jesse, but thank you so much. I'm excited to work with all of you. And as Jesse said, I'm normally here anyway. So now my video will just be on. So, well, not at this moment because I'm still eating lunch right now. So I'm not going to make you guys watch that, but generally speaking, it will be on.
Great. Thanks, Rachel. And Lisa Heaton is not here, but she'll be filling the consumer representative seat. She is the executive director, CEO of House of Hope. And she's been with House of Hope in management and different management positions for over 22 years. And for those of you who aren't familiar, House of Hope is a nonprofit organization that specializes in working with women with substance use and mental health disorders, as well as offering clinical treatment, support, and resources for children, partners, and families. And they have facilities in Salt Lake and one in Provo. So Lisa will be with us next meeting, I believe, and we're excited to have her joining as well. So with that, we have a vote for the next vice chair. And I know that that Sharon sent out a link to committee members. I hope the new committee members probably also received it, but this will be my last meeting as chair. And next meeting, Michael Hales will be stepping in as the chair, and which means we get to vote for a vice chair to fill the role of vice chair and incoming chair after Michael's term ends, which will be 2 years. So I hope everybody got the link and voted. And Sharon, is there anything else besides that? Besides tallying up that link that people need to do?
No, and I am getting ready to post the link in the chat for easy convenience, just for the current MAC committee members to vote. So thank you.
Great. Sharon, when will those results, will those be at the end of the meeting as well? Or do you want to notify the who's ever the person first, and we can share it at the August meeting? What would be preferred? Yeah,
so my intention was to share at the next meeting, but I can definitely give a status at the end. I know that we have some people who are not here, so I do want to give them a chance to vote as well. So
let's wait. We have enough excitement coming at the end of this meeting. Let's wait until August, and that way you can also reach out to people that aren't here.
All right, perfect. Thank you.
Yeah, thanks, Sharon. So I think what happens is in August, I turn over the gavel or whatever to Michael in that meeting. So he'll be chairing the August meeting. Okay, great. So on to the next agenda item, which is our FY 2024 budget recommendations discussion. So you all probably will recall that last month we heard different funding requests, and I do just want to say again how much I appreciate everybody for the requests that you all made and the time that you spent putting that together. And I know that, yeah, it takes a lot of work to put that together, and also to the Department of Health for working behind the scenes. You can see here they estimated the fiscal impact. It takes a lot of work to put that together. So thanks everybody for your work on this. And yeah, this is an important part of what we do as a committee. And but you know, it seems kind of seamless now, but I just appreciate the work that goes behind the scenes to make it happen. With that, we will be voting now if you haven't already submitted your ballot, but this is also a time if there are any questions that committee members have about any of the topics, and some people here, some aren't, but maybe about the fiscal impact, really any of the items, or if committee members just want to flag something. This is just you know, we carve out a few moments in the agenda just for committee discussion or questions. So, and thanks, Sharon's throwing the link in the chat as well. Again, this is just for committee members. But does anybody have any committee members have any questions, or members of the public too, about anything? This isn't a time to make a pitch, but just to clarify or ask a question about anything.
Hey, Jesse, this is Brian. I have a quick question. Are we shooting for a certain amount of funding, or like to stay below a certain amount, or are we okay to rank any of these?
I think that's my personal view is it's really up to each committee member. I think, you know, we have a budget surplus. I'll just so I don't think
Sure.
think feel free to that if that's something you want to consider, that's certainly up to you and what you represent, you know, what you represent. But you know, in your position, if that's something that you want to consider, that's terrific. But it's not something I think that we need to as a committee. So that would just be my take on it. But I think the fiscal impact does help kind of provide that context if that's going to, you know, help inform your decision.
Yeah, I'm just wondering if we were able to fund more of those groups if they were smaller amounts, or okay,
Yeah.
that's fine.
I mean, I'll just be blunt in my final chair moments. You know, since we only have these are recommendations, and we're not the ones, you know, tasked. Luckily, we're not social services committee making these tough choices with funding, but I think this is really a statement of our support and where we value as a committee. So if, you know, if that fiscal piece is part of it, by all means go forward, but I don't, you know, we don't have to make that determination.
Sure.
Yeah. But thanks for that question. That's important. Great. Yeah, does anybody else have any other questions? And so take a moment to be voting on these and get them to Sharon as soon as possible. The form will not let you submit, I have discovered. Well, if you accidentally put two things in a box, so just check for that and get those to Sharon, I would say, in the next couple minutes. Is that okay with you, Sharon?
Yeah, absolutely. And please go in and vote. I've only had 4 votes so far. So please, committee members, if you have trouble with that link or anything, just let me know. And Jesse is correct. You can only vote for 1 per each 1 through 10 or 1 through 15, excuse me. So yeah, please go out and vote, and then I will tally during this meeting, and I will produce the results at the end of the meeting as well. So let me know if you have any troubles. Thank you.
And one thing, oh, Christine, I see you have your hand raised. One thing I just want to say too is I think just having these a record that these are important priorities, I think is important just for us as a committee. And I mean, there's a certain amount of subjectivity, of course, in the rankings, but I think it's really about, you know, getting these. It's a really important way just to get these forward. And so I just wanted to mention that as well. Christine, you had a question or comment?
Yeah, will you remind me the LTACH, what does that stand for? Does anyone know?
Karen, do you have that up?
It's the long-term acute care hospitals.
Okay. And then I don't know how I'm not remembering this. So ensuring access to complex rehab technology, is there an example that they use that I'm not remembering?
Well, actually, Sharon, do you have that? I was thinking it was, well, I'll let somebody else answer if they want first.
Yeah, I'm not recalling an example off the top of my head, but Christine, I can maybe send you their presentation really quick if that would be helpful to you.
Oh, that would be good. I mean, I think I know what they're talking about, but I just want to make sure.
Okay, let me email that to you real quick.
Okay, thank you. That's it.
Oh, thanks, Michael. Yeah, and if anybody wants to answer Christine's, I just want to make sure that we have that. Thanks, Sharon, for doing that, that it's being accurately captured. Okay. All right, any other questions, clarifying questions? Thanks, Christine. That's important. Anyone else? Okay, great. Oh, yeah, Jennifer.
Oh, can you hear me?
Yeah.
Looks like the next item on the agenda is committee member updates. Is that correct?
Yes.
Okay, yeah. I have a guest that when you're done with what's on the agenda would like to briefly speak to the group. So I wanted to make sure that he got a chance to speak during this next part of the agenda.
Oh, great. Okay. Yeah.
Thank you.
So, so with that, so we're on committee member updates. Are there any committee member updates? Any committee members? And this is time that we have in the agenda to share, just for Rachel, well, Rachel, you know this, but Davis, the way that our agenda typically works is we have the approval of the minutes, and we don't usually have budget recommendations, but at the beginning of the agenda, for now, what we've been doing is having time for just committee member updates or questions, or just kind of an open time if there's anything that committee members want to flag. So that's where we're at in the agenda, and it's kind of an open forum if there's anything that people want to share. Adam, yeah.
Hey, this is Adam, back from the old days.
Yeah, hi.
Nice to see you. Hey, so we've got some concerns with the inpatient hospital units, making sure that those are recovery focused, making sure that those are staying up to par. I've gone to them. I wasn't really impressed, but I recently was working at one, and man, seeing what's going on behind the scenes, seeing the way they see their patients, as they say, the reasoning they use, and the lack of accountability to the recovery of the patients. I mean, it's all nurse reasoning, it's institution error reasoning, and it's very scary. So I did some findings on what's going on and what we need to fix it. Where is this coming from? Where is this idea that, we need to put people in hospital beds because they're sick, and what's keeping this from being the 1940s to the 2022? And there's a lot of things that can be easily fixed, a lot of things that we can go in and we can actually make this a proper 2022 behavioral health program for short-term crisis stabilization. So I'm going to go ahead and we're going to work with a few groups, MCAC as well. And I know recently when I was exiting, we did some work on these inpatient hospital units, and I remember sharing some deinstitutionalization poetry, and I think it's very important we get this corrected as soon as possible. It's one where I've interviewed the clients, I've interviewed the staff, and it's one where we need to make some actions urgently, just to make sure that people are going into those programs and they're coming out empowered. They're coming out with the proper focus. What's going on right now is it's led by the hospitals, and so it's very accountable to the hospitals. And so you're seeing a lot of reasoning that's appropriate for medical field, but not appropriate for the behavioral health field. And so having that accountability not to the recovery community it's dangerous. So peer support, I mean, having some link to recovery, the people not, in recovery and what they've seen to work, ethics trainings. I mean, there are a lot of things we can do quite easily to make these up to par, but the staff's wanting more training. The clients are wanting more. But it's just the structure, it needs to be restructured and it needs to change. So I'll be doing some more research this next month, and I'll do I'll give you more findings in ways we could change that billing code. But it's one where I don't think we can wait till next June. I think this needs to be addressed as soon as possible, if that makes sense. Sorry, that probably took too long.
Thank you, Adam.
Thank you, Adam. Can I ask a question? So when you were saying the hospitals, are you referring to what stage of the recovery process? I guess if you could just clarify so I can make sure I understand that. And I appreciate you sharing all of that.
So a big one we did, and if I remember right, the Denver system, if you are going through a crisis, you go into one of these Intermountain Healthcare, Lakeview Hospital. I mean, there's various other ones, and they'll have a wing for behavioral health, right? And that is meant because we don't want to take people out of the community. We don't want to take them out of their job. So you've got long-term programs out there, certainly, that will really, really do that. But these are for, hey, I'm feeling suicidal. I'm just having, rough time, mental health, paranoid, lower level clients oftentimes. Not state hospital. Intervention in these.
Is Adam freezing for anyone else? Okay.
Did you hear all that?
You broke up just a little bit at the end.
Oh, okay. It's just me ramblings. Does that answer the question? A tough one.
So it's like the crisis, like the immediate, maybe is it short term, and then they're typically transferred to a more transitional, a more behavioral health specific facility, or?
No. So this one for most people is going to be the treatment, right? We don't want to take them out of their job. And so this is going to be, what I was thinking, a lot of people who are suicidal. That's the large point there. A lot of people with bipolar love going in, separate from the community, as well as schizophrenia. But this is meant to be short term. And then, there are social workers that are linking them up to the long-term ones. But we're actually having a hole right now in the more long-term treatments. It's not being filled.
Do you know how long the typical stay is for the population group you're talking about?
Yeah, so we were careful to keep it short. So it's about 4 days. But they're taking some people and putting it out for weeks unnecessarily. Really depends.
Is this for Medicaid patients, Adam, or just kind of everyone?
This one's for everyone. So we can work on Medicaid, but we're going to be working with various groups to do this. I don't know the best place.
And I'm not going to get into it in detail, but I will say that some of the health centers actually have problems getting Medicaid folks specifically into inpatient treatment and regularly get denied placements for inpatient that they do need. But again, I won't get into it, but that is something that we've experienced. So
I'll take a look into it. Yeah.
Thanks for sharing, Adam.
Oh, the one I worked at, Intermountain Health. I've also gone to Lakeview Hospital. So those are the two programs I'm mainly referring to. Cool.
Thanks, Adam.
All right. Thank you again, Adam.
In terms of so I guess what would be ideal for this committee going forward? Jennifer or Adam?
I can write up some ways to change the your billing code, change how we get people into there. But also if there's anything we can do to get peer support into there, anything we can do to get accountability to the recovery community and training in recovery in those settings needs to be done. And anything you all can do for that is going to be greatly appreciated.
So they don't allow peer support specialists in the hospitals then, or?
Yeah, there's some old views that they'll seek treatment or cause a problem, but I mean, in the addiction recovery world, everyone's peer. So in these programs, they don't allow it. They won't even let you say, I'm in recovery. And it's a shame because we're probably the better ones for it at this level.
So if I walked in, Adam, as a certified peer support specialist, then they would not take me seriously at all. They would assume perhaps that I was there to seek treatment or that I was there to cause trouble.
Yes, so nurse reasoning and peer support reasoning clash. It's the old deinstitutionalization era clash. And so they won't let you in with the patients. They'll let you in with certain receiving centers. They'll let you in with other groups, but with the actual patients, for some reason, they don't want to clash between the peer support and the nurses, which is honestly quite unethical in my opinion.
Yeah.
Is there anyone from the hospitals here? Oh, sorry. Go ahead, Jennifer.
No, go ahead, Stephanie.
I was just going to say, is there a hospital representative here that could like comment on whether or not they can go and like find out if there's like a specific, I mean, if there, yeah, is there like a regulation or is this just like decisions made internally that they can go look into this? I don't know. I mean, I guess maybe Jesse, that was part of your question of just how can we make sure that this information is gets to the right people? I think it's important. I mean, it's like, I'm glad that y'all brought it up, but.
I said to Adam, there are some individuals with other organizations that we can speak to on this matter. My intent is not to kick the can down the road. I'm just saying their hands are more actively involved in certified peer specialists and keeping trainings updated with mental health professionals. So, I mean, that's something I can do with other organizations.
I think a big one to recognize, though, is if we don't do anything, nothing's going to change. It's quite apparent.
No, it won't. Yeah.
This is run by medical facilities and through medical reasoning, and it's not going to change unless we do something.
So, yeah, my experience mainly goes through, for example, the Utah mental health authorities. And I know that certified peer support specialists are very well integrated into those systems. But I don't have experience with, like what you said, IHC or Lakeview. Is that the other one? Yeah.
Any of these big stabilizations.
Okay. Yeah, that's very concerning. Did anyone have anything else to add? Okay.
Thanks again for making this time. And Adam, thank you so much. Also good to see you again, but I wish it was under better circumstances. So,
yes, thank you, Adam.
Thanks, Jennifer. So, and if you want to make this something that we revisit at a future MAC meeting, we certainly can too. Like we could put it on the agenda as a formal thing to keep that on the radar as well.
That would be great.
Okay. Well, I mean, yeah, why don't we circle back with you as we're planning the agenda for the August meeting, and that would be a good way to see if it's how you want to proceed there too. So, okay, thanks. Actually, sorry, Colby, one quick thing before we move on to the update. I also, I did just want to make a recommendation, take the kind of chair prerogative, I guess. as I'm leaving, and it's really great to see the new members here. And we will have a few more seats opening up, including the provider seat, like Dr. Cosgrove's seat, and actually my seat will be opening up. So please be keeping in mind that we will have some openings on the MAC, and we have a really great flyer that we'll put in the chat again, specifically geared towards getting more beneficiaries or enrollees involved. And one thing I would love to just see going forward, we've sort of inherited this system of selecting new members that that we might want to revisit. So I just encourage new leadership, Michael and who's ever in the vice chair and member at large seat, to maybe take a look at how we make that selection process. It kind of runs up through the chains of the department, but I think other state Medicaid advisory committees might be looking at different processes in terms of how they bring on new members. So that's something I also just want to flag and recommend that be looked at for this committee in the future. And if there's a different way we might want to make the selection process. But overall, I just think, please, if you have questions or you're wondering if somebody would be a good fit for the MAC, or if they, how it would work for them, just reach out to myself, to Stephanie, to Michael, or anyone on the committee in terms of getting the word out about the seat and the seats that are open, and also and how to support people on this committee. And then, as I said, for this, the incoming leadership, please, take a look at how the process goes, the selection process currently happens, and if we want to take some, revisit that and maybe update our process. So with that, unless anybody has anything they want to add to my kind of thoughts and comments.
I'll just add that I think I've just been thinking a lot about how different the experience of Medicaid is geographically, and just I think that there are some ways that we can try to be more mindful about having, I think there are just, a few different objectives we might want to think about with being a little bit more inclusive of who all gets represented on the MAC, but just thinking about, the way that, the one that I guess has come up is just that right now the provider perspective is, I guess, exclusive to physicians, and that in rural communities, though, it seems like nurse practitioners and PAs are, they do seem to provide, at least from, different anecdotes, I don't know what the data says, but it seems like they do provide a lot of care for Medicaid members. And in some communities, when there is very, very little access to physicians, these nurse practitioners and PAs are filling an incredibly important gap. And so anyways, I don't want to get into like all of the different fights between different provider groups. I just have been thinking about how we can maybe try to think about how those spots can be a little bit more inclusive, so that the experiences of Medicaid members and those who provide care for them can be a little bit more representative of the population.
Sorry, I was on mute. Thank you, Stephanie. I think that's also important to look at as well. And I think we're actually due for probably a bylaw update as well. So I'll leave that to y'all as well. But I think there's probably a few things that could be updated in addition. And the last time we updated was 2 years ago, but which was pretty thorough. But I think there's some additional things we might want to just revisit. So great. Thanks for sharing that. All right. Anything else from the committee members? And I'm glad we have this time, and hope it will stay on the agenda moving forward. And thanks, Jennifer and Adam and Stephanie, again for sharing. And with that, Colby, the time is yours to talk about Medicaid and CHIP outreach.
Great. I'm going to share my presentation here. with everyone so that we can go through it together. During this, the 2021 legislative session, the department was appropriated funding to outreach to children, specifically for both CHIP and Medicaid, so both children's coverage programs. And I'm just going to walk you through that campaign. It was our first year of implementing this this effort, and the first year that we've had funding in many years specifically targeted to outreach and promotion of the program. So we were excited to have some dedicated personnel and funding to be able to do so. So it was HB 262 of the 2021 session where we were appropriated this funding. The first 6 months of the funding, July to December, we were really trying to get the administrative kind of hurdles down. We had to hire an outreach and marketing agency, as well as hire an outreach staff member. So we were able to get both of those secured, and then we were able to roll out the campaigns beginning in January. The agency that we were able to work with is Target River. They are on contract with the state, and they are the ones who implemented much of this effort. We are going to go through all of these individually on the next slide, so I'm not going to walk through this slide by bullet right now, but we'll do in more detail moving forward. So the first effort was really our social media and display advertising. So you can see here that there, through display, remarketing, Facebook, Instagram, search, that we were able to garner many, many impressions. And then the click-through rate really depends upon the actual platform. So the platforms vary depending on how they're utilized. For example, Instagram doesn't make it easy for you to click through from an ad using a URL. However, Facebook is the opposite, where you get a lot more engagement on Facebook. So you'll see that in the data here. But we used a number of methods to really target and outreach to the communities with high uninsured rates in the state. We were also able to develop advertising videos that were used on YouTube, OTT, pre-roll, and then broadcast television. So OTT, for those that are unfamiliar, is the power of traditional television, but with targeted apps. So for example, you would watch a traditional program like that you would see on your regularly scheduled channels, but it is through an app like Hulu. So there's pre-roll and advertisements in those platforms. I'm going to share really quickly one of the ads that we
Life is full of fun and unexpected scrapes and bumps and bruises and, well, you get the picture. With Medicaid and CHIP, you can keep your adventurers on course and full speed ahead. With medical, dental, and behavioral health care coverage, you will have peace of mind knowing that whatever happens, your kids and teens are covered. Learn more about this free or low-cost health insurance and apply today at coveringkids.health.utah.gov. Give your kids the protection they need and deserve.
So all of these advertisements, videos, any promotional material that was developed has been done in English and Spanish. So these are available on our website if you want to watch both the English and Spanish versions. The next tactic we used was direct mail. We specifically targeted zip codes throughout the state that had a high percentage of individuals who would qualify for Medicaid, and we utilized data collected by the department. 32,000 mailers were sent. Front and back, so English on the front, Spanish on the back, promotional material that had information about the program, how to apply, and what the coverage benefits include. We also were able to partner with some sponsors, and one of the sponsors is doing a number of events throughout the state where we were able to do contests and such. People submitted their information to be entered into the contest, and then we remarketed to them to remind them about the programs and give them direct links so that they could apply. These were the sponsorship entities that we partnered with. Broadway Media, we did a number of interviews. We're able to do a 30-minute interview with Jeff Nelson regarding the program specifically. We did various contents. Alpha Media, we specifically partnered with. They do Spanish-speaking radio, and so we have some events there and some on-air promotions and commercials and streaming throughout their program. We also partnered with Real Salt Lake, which we had a booth at all 14 games. We had in-game advertising, spots during the game, and then also pre-game advertising, which this was a fun partnership for us because we really feel like we can target that the Hispanic Latino population specifically, who are, you know, very interested in and closely follow this team. And then we've been able, with these sponsorships, participate in a number of community events, the Easter egg hunt, Cinco de Mayo, Juneteenth, a sticker smack, a Latino festival, and then upcoming this Latino festival and health fair. We will also be participating. So they've given us an opportunity to attend their events and have a presence through their promotions. We also have worked closely with ABC4 Utah on the Daily Dish, and we've been able to have interviews nearly every month since March with various professionals who have different perspective related to the programs, but have been able to promote the programs through their professional experience. And just recently, Jennifer Strucker was able to talk about the unwinding, which is important that we are starting to get that message out to these families. We've also, you know, targeted community organizations like rec centers, school districts, chambers of commerce, WIC and food banks, charter schools. We've outreached to the city, county, and state elected officials. To clarify for chambers of commerce, because that doesn't seem like a direct connection, we've been able to promote the program as a benefit for businesses who have employees that may not have insurance coverage, whether it's available for they don't have available for their staff or their staff's family. So this was a way that we were able to feel like there was an important connection in the business community that can be made that is not maybe currently people are not necessarily aware of. We also did various radio and audio advertising. You can see 1.5 million impressions through streaming audio. We did various interviews on various stations, PSAs, social media posts by the stations regarding the programs, over 7 million impressions through radio. And then we also have these event sponsorships, which is over 600,000 impressions through that. I'm going to play one of these. Now this is specifically for RSL, so
Real Salt Lake loves its fans. You can score a win for your family by kicking healthcare woes to the curb. By getting free or low-cost healthcare from Medicaid and CHIP. Sports and other activities come with bumps, bruises, and broken bones. Get the coverage to shut out high-cost bills from a lack of coverage. With Medicaid and CHIP, your kids and teens may qualify for free or low-cost health insurance. That's great news for everyone. Keep on playing. Check out coveringkids.health.utah.gov and see if your kids qualify. Or visit the ESPN pregame show at a future RSL game to learn more and a chance at some great prizes. Real Salt.
We were also able to secure billboards across the state. So if you've driven on I-15, you've likely seen some. We again targeted them based on the uninsured rate data. We had both digital and static billboards, and the locations are listed here. Some are still up, so you may still be seeing them as you're commuting or traveling. We were able to update a specific landing page that was designed for children. So we wanted it to be easily understandable for parents, a place for them to go to get information about both programs, both CHIP and Medicaid. This type of information really has not been available on the website where it has information specifically targeted to children. It has the income guidelines and then how to apply. And this was also developed in Spanish. So there's a Spanish page, and you can see that those videos are posted right there on the page. And then we also developed a flyer and a poster that we have used to distribute, and our outreach specialist has been distributing all over to organizations that touch our potential audience. We developed some banners that have been used at the various events and retractable posters as we are going and attending these types of community events that we have a presence and that people are able to quickly understand what our booth is representing. So here you can see some photos of a recent event. Our outreach specialist has really been in the weeds doing grassroots outreach and participating at community events. You can see that, you know, as it's just gotten warm and with COVID, things are just starting to get back to normal with these types of activities. So he has been going to various events, and he has a number through the summer and through the back to school and fall time. So if you have events that you're aware of that you would like our participation, we would ask you to please send them our way so that we can be there. Just as a quick summary of the entire campaign, now this was just our first year and we only started in January, so it was just January to the end of June. We had over 66 million impressions through our you know, TV, social media, direct mail, or audio and outdoor advertising. Right here is a summary of the events on the website. So we had 25,000 clicks onto the website. We tracked 2,900 website events, which is where people actually showed interest and then clicked through to an actionable button on there. And then we had over 900 calls that were directed to the health information line, which 73% of those calls lasted longer than 1 minute, which indicates that people were asking questions and getting more information in more detail than just a quick yes or no answer. So that's a real comprehensive summary of the activities that we've been doing. And yes, I would like to open it up to questions if there are any out there. So Kimberly, it looks like you have one.
Yeah, Colby, thanks for that presentation. It was great. I had a question about the number of calls that you received as it compares to the past. Did it increase after the campaign?
Yes, there's certainly been a significant increase in calls. Now, this is because we really haven't been promoting the program through all these efforts. I think if you were to compare it to 10, 15 years ago when we had funding to do this type of work, the call volume would be lower, but we also were not utilizing the internet and social media like we do today. So it's just a different environment for communication. And so people are using the websites, the links, information online to get their information versus calling in. So yes, I would say there's been an increase, but you can't quite compare it to what we've seen in the past when we did have funding similar to what we've got today.
That makes sense. Thank you.
Sure. Any other questions? Stephanie?
Hi, Colby. Thank you so much for this update. I remember the last time we talked about this, I had asked about churches, and I'm just curious if you all were able to, and that has come up by like community health workers and just like other Medicaid members that I know, and families who would qualify for Medicaid. A lot of them do have, a lot of people do access like their needs through their church. And so I'm just curious, and a lot of community health workers work within churches and church kind of organizations. So I'm just curious if y'all were able to do any of that.
Yes, I know I specifically passed that feedback on to our new outreach specialist, and he has been passing along materials and posters and information to many contacts within various religions. So I know that that is on his list of touch points across the state. So yes, we've certainly taken that feedback and we appreciate it.
Awesome, thank you. What about workplaces?
If you see a place that would be a good spot for information, or if you have a contact, please pass that along, because we would love your recommendations and referrals as well.
Yeah, I can send you somewhere that might be helpful. But then what about workplaces, like work? Is there ever, I don't know if that would be helpful or not, but just like the industries that might be more likely to, I just don't know if that
was our goal with working with the chambers of commerce, right? To pass that along to their members to then utilize within their businesses and organizations. And so that was a way that we could get through a larger organization and try and reach more businesses in quantity. I wouldn't say I have a comprehensive list of where that's been implemented, though. I just have a list of what chambers we've worked with. But I know our outreach specialist has been like boots on the ground, getting flyers up in grocery stores and libraries and places that people would be, that they could see and be reminded or learn about the program. But again, if you've got ideas, send them our way.
Yeah, I'll send you an email. Thanks, Colby.
Great, thank you. Any other questions?
Colby, I might have missed this, but can you remind me, what are the communications firms that you've been working with that have been putting this, like putting the what's it, the content, like the images and the, yeah.
Yeah, we've worked with Target River.
Okay. And they're the ones that put like the ads and the, okay, great.
They've done all the design as well as ad buys for us. So they've largely led this effort.
Yeah, and I think one thing, just you know, it was very fun to go on the show, the ABC4 show. But you know, if there's any way to...
Oh, you've muted yourself, Jesse.
Oh, sorry, I don't even know how I did that. I just noticed that list, you know, we were all like white, rather professionals. I think also having some people that not white, or people that are from rural parts of the state, or just might resonate with different folks, you know, moms. I think that would be really great to see in the future too, because, you know, hopefully we connected with people, or I know there's that value to have that kind of professional or doctor person, but also I think different ways to connect and resonate, just in the ads and in the TV slots.
I fully understand what you're saying, Jesse. One thought is, if you have context that would be good and comfortable in that environment, for example, a family member, you know, a parent that could speak to the programs, that could, you know, speak to their experience, but also then represent the programs. I think that would be interesting to pursue. It's a pretty intense situation to be on live TV and have that conversation. And so I wouldn't want to put anyone in that position that isn't comfortable and familiar with that environment. So I also want to be careful about who we put there.
Yeah, totally. And I know it kind of came, you know, it's definitely, yeah, it takes some prep and everything too. So people's timing as well. So. Yeah.
Right. But we do continue to have a relationship with that. In fact, I got an email from the news director today saying, here are our openings for August if you want to take a slot. So if you do have recommendations on who would fit that, we have the opportunity to continue to speak on that platform.
Great.
Anything else? So just as a close, this funding is ongoing. So we will, you know, with the next fiscal year, continue to implement a similar type campaign, and then also be looking at some other options for opportunities in the future.
Hey, Colby, sorry, one more question. It's ongoing, like ongoing, or is there any, I thought so as well, but then I just wanted to double check. So it's ongoing. Great.
Yep, we have funding for fiscal 22 and nope, 23. So I have a budget and we're moving forward.
Awesome. Great.
Thank you.
Okay, thanks again, Colby. So next up on our agenda is Jennifer Strohicker is going to give some updates on our waiver. So over to you, Jen.
Yeah, thanks, Jesse. Hi, everyone. Nice to see you today. Wanted to give an update on our 1115 waiver. This has been ongoing work that we've been doing in collaboration with CMS to have a 5-year renewal put in place for our 1115 waiver. And while it was recently approved and extended effective July 1st through 2027, it did come with some significant changes to the waiver as we have known it. And so what I'd like to do now is walk you through this blurb we have written here and really highlight what these changes look like. So I'm not going to read it to you, but I want to highlight some of the elements that were important to us as we walked through what CMS was asking and what this will look like for our Medicaid program. So first of all, we have called our waiver the primary care network demonstration for many years. With this renewal and the updates that are now in our waiver, it will be known as the Medicaid Reform 1115 demonstration. So technical terms, I know, and certainly on all of our documentation with CMS, but just for familiarity for you, there has been an official name change to our 1115 waiver. As I mentioned, it is a 5-year renewal, so it is effective July 1st, 2022 through June 30th, 2027. Let me see if I can make this just a bit bigger. Now to the meat of what we'd like to share with you. So CMS's approval was contingent on some important changes taking place with our existing waiver, as we have had it and operated for a number of years. And primarily, what we have as our first bullet is that our non-traditional benefits will no longer be authorized through the waiver as of December 31st, 2023. So CMS recognized that we are in the midst of a very large system implementation with our PRISM system, but it's also very important to them and the current administration that we offer a full traditional benefit package to individuals who have previously received the non-traditional benefit package. So what does that look like? You know, from a operational standpoint, what this means for members in the non-traditional benefit who will be moving into this traditional package is transportation benefits. There are also a handful of other services that will change, not necessarily that are new, but that are offered in different quantity limits, such as physical therapy and occupational therapy, and items such as transplant services, for example. Different types of transplants can be covered under the TRAD benefit. As we go through our work to really bring the non-TRAD population to a traditional benefit, we will bring these updates to the MAC so you have transparency in what these policy changes look like. We have a large work group that's in place now to really wrap our heads around all the work that's going to take place over the next year and a half. Now, since CMS did give us to December 31st, 2023 to implement these changes, we are actually opting to implement this update within the next year. So we would like to have this go live July 1st, simply because with the alignment of our contracts, our rate setting, you know, our managed care entities, our various vendors we'll be working with, it makes more sense for us to do it on our state fiscal year. So we're aligning all of our work so that this can be done and completed by January 1st, or I'm sorry, July 1st of 2023. Specifically, when you look at the populations within the waiver that are affected, there are two different groups that have been called out. The one is our non-traditional population. These are also called our current eligibles. For those of you who may be more familiar with waiver terminology, but this will be the parent caretaker relative Medicaid group that will move from a non-traditional to a full traditional package. Also, those in the adult expansion Medicaid who are adults with children. So those are the two groups that will be affected. Also, it's important too that we will also give EPSDT benefits to 19 and 20-year-olds who are in these groups. So quite a number of changes, really, when we look at the amount of work it is that is needed to kind of implement these different pieces. But we're scoping it now and beginning the work on that, even to the point of just programming our systems to support these changes. So the second change that CMS has asked for is we've allowed to have, we've maintained our PCN language and our program description in our 1115 waiver historically. while we're not actively, as you know, when expansion began, our PCN population went away, but they've asked us to remove references and the authorities that were defined in our waiver for the PCN population. So that is a piece of cleanup we're going to need to do. And then, as you know, these individuals are now covered under our adult expansion population. There are a number of things, if you're interested in reading the official release or more information on our waiver specifically, you can certainly click on the hyperlink, and I can share that here. Oops, I won't do it here in the meeting, but I can certainly share the hyperlink if you're interested in learning more about the waiver. What questions do you have for me regarding the 1115 waiver updates?
Hi, Jen, this is Julie Ewing. I wonder if I can just jump in and ask a question. So recently we talked about in some of the TAM work groups that a waiver was being submitted to allow individuals who are incarcerated to submit their Medicaid application sooner so that it could get processed sooner so they would have coverage immediately upon being released. Is this that waiver, and did that piece get approved?
No. So Julie, this is that waiver. The piece that I think you're referring to is an amendment that is separate around individuals who have been incarcerated and looking at justice-involved populations that way. That piece is still on hold with CMS. So there are various elements to this waiver. The TAM population is another element of this waiver as well. And the piece you're referring to, the justice-involved amendment, is still with CMS. I think they're doing some work at the federal level to really work on this offering, and have not allowed us to proceed forward with that amendment request. But at this time, yeah, these pieces won't be affecting those other elements that are in the waiver.
Okay, thank you.
You're welcome. Jesse.
Yeah, I'm curious, I seem to recall that there's currently the non-emergency medical transport benefit for parents under like our pandemic rules. Is that still the case? I'm just wondering how that relates to these changes. Or so do parents currently have the non-emergency medical transport benefit?
Right. Good question, Jesse. So we did put some expansions on, we expanded our transportation benefit as a flexibility of the public health emergency to allow our non-traditional population to receive NEMT for the purpose of receiving COVID-related services. So that is still in place, and it will continue through the duration of the PHE. So that was a different contractual arrangement that we made with our NEMT vendor, so that individuals who needed to get testing or treatment or vaccinations could do that by using Motive Care. Okay. So this would actually go beyond that and allow not just COVID-related services, but for any medically necessary service.
Great.
Okay.
Thanks.
There's much more to come on this. So as we do our work, we'll bring it back to this group so you're aware of where we're at with this important project, and before it goes live in another year. Okay. So just to give you a heads up today on some of these changes, they certainly do influence our Medicaid membership, and wanted to just give you transparency into that and let you know that we're going to be doing our complete work to implement this in another year.
Great. Thanks so much for that. That's really exciting. And if you have information at a later date around the number of people that you expect to be impacted, specifically I'm thinking like the 19 and 20-year-old group, but that might be interesting just to know, since there'll be some additional benefits that they'll be eligible for. But thanks for just sharing that and keeping us updated. So I'm excited.
Okay, sure, Jesse.
Great. Okay, Michelle, you're up with Michelle, the floor is yours now with the the eligibility and enrollment discussion. I could have been a little kinder instead. You're up now.
No, that's great. Yes, thanks, Jesse. Yeah, let me get my screen pulled up here. 1 second.
And you're giving the eligibility and enrollment update around, will that include the expansion update too this time?
Yeah, I believe when I did speak with Jeff before he left on his very exciting vacation, and that's why you guys get me today. I think he said he doesn't necessarily go through those in detail anymore, but I think if you guys would like me to, I'm absolutely happy to pull those up and go through those in detail. So I think just let me know.
Yeah, Michelle, before you start, I think it's probably obvious, but just for our new members, there's some things in every agenda that are different, but then there's also some times that we kind of try and keep in every meeting around just giving updates around the eligibility and enrollment of Medicaid and CHIP members. So this is one of those standing agenda items. And so you'll see this or some iteration of these charts and this information shared at every meeting so that we as a committee can just keep aware of what's happening with the trends in Medicaid overall. So thanks, Michelle.
Yeah, no problem. And would you like me then to go through each of those reports, Jesse? Because I can pull those up first if you would like.
I think if we have time, that would be great.
Okay.
Yeah,
that's great. I'll go ahead and do that first. Great. Okay. Okay. Are you able to see my screen? Okay. So first here, I don't know if you guys can all see that. I'll try to make it a little bigger. These are the Medicaid trends. This was also shared with everyone in the meeting from Sharon. So if you have that attachment, you're also welcome to look at it. You might be able to see it a little better if you pull it up yourself. But just to point out, I mean, nothing really surprising. We're still seeing increases in enrollment due to the public health emergency. I think each of our groups are showing that increase. If we go down to the chart here, just overall, that huge, mountain there with Medicaid has gone up. And then, of course, you see PCN tapered off back in April when we started adult expansion. And then CHIP, you can see kind of the dip from last year when we had to go through that activity of kind of unwinding our CHIP population. So that kind of explains that little cliff right there. Scrolling down, here are, again, each group shows, that increase. Adults, fairly large increase. People with disabilities, our aged population, and then with our pregnant women, just kind of the same there. So that's the Medicaid trends. I guess I'll pause here and just ask if there are any questions from anyone.
Okay, Michelle, I'm wondering, I was trying to get it pulled up on my screen quickly too. Are we seeing any changes in the pregnancy group now? Because now you don't stay on the pregnancy Medicaid if you're eligible for other programs, right? I'm sorry, after the 60 days postpartum, is that correct? Like it used to be that during the initial PHE period, we were keeping pregnancy cases open?
That's correct. And then we received the additional guidance from CMS that allowed us to move individuals to, if they stayed within the same tier of benefits, right? And so, yeah, we've definitely, had movement with our pregnant women population into those groups, whether that be adult expansion, parent, caretaker, relative, wherever that individual might fit based on their situation. So, yeah.
What would happen? I'm just curious, like, because we're under the PHE and people can't be disenrolled, if somebody was found to be just like not eligible, slightly over income, let's say, right now, what would happen to somebody in the pregnant in the pregnant category?
So even outside of the public health emergency, if someone is pregnant or during that, pregnancy period, the 60-day postpartum, and if they had an increase in income, that does not affect their eligibility. So, after the 60-day postpartum and when, we move them to a different program, during the public health emergency, if their income increases, obviously we're not closing for that reason. The only reasons we're closing right now during the public health emergency is, you know, someone who's moved out of state, they request their case closed, or death. So those are the three reasons.
If somebody was over income, would they stay in the pregnant category, or would they move to a different category still, even if they weren't eligible because of the financial threshold? Do you know? I'm just wondering, like, how do we? Because yeah, if so, you're slightly over income, you're moving out of pregnancy, 60 days postpartum. Where would you go since your case can't be closed?
So more than likely, we would move them to adult expansion Medicaid. Yeah. Does that answer your question?
That was what I was wondering.
Okay, perfect. Okay, great. Any other questions on this? Okay. I'll go ahead and share the expansion report, and I'll just briefly, you know, kind of go down through this. As you guys can see, you know, just with the previous chart as well, adults without dependent children has increased, the parents have increased, and TAM slightly, targeted adult Medicaid, excuse me. we get used to acronyms over here. So our targeted adult Medicaid group, you can see as well, has kind of slightly increased over time. Going down to the next page, you can see by demographics, you know, just by different counties, what our enrollment is, age group. We also capture race and ethnicity, as well as gender. Looks like we're pretty equal there, 50-50. And then we've got this broken down with town enrollment by month and by the different subgroups that are within town. So as you guys can see the different groups there and kind of how they fluctuate somewhat. Also, if you're interested in the exact numbers, it's just below that chart. And then down, we capture just monthly town expenditures for each of our groups and the different services. And again, actual numbers are below the chart. And then we have further breakdown, total expansion parents enrollment by month, and then it's broken down by FPL, the federal poverty level. So you can kind of see where people fall within each of those FPL groups. And again, down here, actual numbers. And then services as well, we have broken down for parents. And then for adults without dependent children by each month and their FPL groups that they fall in. And obviously you can see the 0 group is fairly high. And then expenditures for that group as well. And actual numbers below the chart. Okay, so I'll pause here as well and just ask if there are any questions.
Michelle, I had put in thanks for medically assisted treatment. My other my other question is if you scroll up, and this just might be me, but for the race ethnicity category, so what it looks like, let me see if I can see it on here too. Yeah, so it's white non-Hispanics and then other non-Hispanic. So that would be kind of other categories. So that just shows that a lot of people just choose other and they don't label a race or ethnicity. Enable. Is that correct? Okay.
Yes.
Okay, great. Thanks.
Yeah, no problem. Any other questions? Okay. I will move over to our monthly PHE report. I believe Jeff shared this the 2 meetings ago, so I think we're a month behind. We've added this chart at the top of this summary page just to kind of show you all just what we're looking at in terms of total individuals that we currently have open on Medicaid. And we've done just kind of a snapshot over the 3-month period. So for April, May, and June. So in the purple, we have our total. And just a note there as well, and I clarified this with Brian Roach, who is our expert on enrollment numbers. But this does include our Medicare cost sharing numbers. So if you guys are wondering why these numbers look a little different than the Medicaid trend report, that's why. So the purple is the total. And then in the blue, I know for those of you who have seen the slide deck for the PHE unwinding, and I believe Jeff presented on that a couple of meetings ago. He discussed the group of individuals that we are keeping open during the PHE that we have, we consider them our backlog individuals. So for example, they're either over income or over assets, or they have not completed their review. That's this blue chart of individuals. And you can see that slowly goes up each month over that 3-month period. So that is slowly growing over time. As I move down here, most of you probably know, maybe some of you do not, but we did receive the COVID-19 public health emergency on July 15th. So that extends us through October 13th of this year. What that means, if they are going to end the public health emergency in October, we would expect to receive the 60-day notice that CMS has promised states on August 14th. So if we don't hear by August 14th, we hope that they're keeping their promise, and we can assume that we'll probably receive another extension. So just a note there. And then just some information on some communication happening. We did launch our webpage for the public health emergency unwinding. There is a lot of really good information on that page. You can read about our plan that we've put together for our eligibility process. It's also going to eventually house our eligibility metrics or dashboard that Jeff has kind of, I think, showed a snapshot during the slideshow that he went over. On that dashboard, we'll be presenting how many cases are yet to be reviewed, where did people go? So just looking at outcomes, did we send people to the exchange, or, have they, failed to complete paperwork? And we're trying to reach out to those folks. So we'll have information on that, as well as call wait times, applications, whether they've been approved or denied, and kind of what that looks like, and any sort of increase in fair hearing requests. So that will all be captured on that dashboard. Another thing to note on communication, the work group that was created a few months back out of the MAC meeting, the notice work group that includes various stakeholders and individuals from the community, as well as our agency and DWS. We meet monthly and review notices. The last 2 or 3 months, we've been focused on our unwinding notices that we're trying to draft and get ready to send out when we do get that 60-day notice, just to better inform individuals of what's to come when we get that 60-day notice. So we're really glad to be able to have that work group. I think that's been a huge help. And I can speak from our perspective. We've really enjoyed getting feedback from you all that participate in that and help us to make those notices more meaningful and make better sense to our members. Another thing to point out, and I don't know if Colby might still be on the call, but she has created a partner and provider toolkit that will be released. She let me know next week. This will also be posted to that webpage that I mentioned. So that will be coming soon. And then moving down, I don't know if Maris is on the call, but if you want to chime in, I'll do my best to kind of give a brief overview on this. Okay, great. Thank you. I don't know if you want to talk about this pre-unwinding activity with address cleansing and Equifax. Okay, great.
Yeah, I can take a couple of minutes to do that. So some of you may be aware, in preparation for the unwinding and making sure that we're sending reviews to proper addresses, we've with Department of Health and Human Services contracted with Equifax and have sent them a first batch of about 104,000 individuals to confirm addresses. They're looking at various financial institutions. They're also gathering information from the post office, I believe, as well as any utility company, and have provided us a list of 98,000 individuals with an updated address. We've actually brought some old people that we have, former retirees, I shouldn't say old people. We have brought back some former retirees to help us with this process because, resources are tight and they've been working on this for the last 5 weeks, I believe. So far, we have gone through roughly about 14,000 of these records, and what we are seeing is from the match, there's about 6 to 8% on any given week that we are having to update the address because the addresses we have in the system are incorrect. We're hoping to have this done before the PHE declaration arrives, so those reviews will start mailing to proper addresses. And we'll kind of worry about resources if we have to increase those depending on what the PHE announcement is.
Okay.
Hey, Maris, this is Brian. Can I ask a question real quick?
Go ahead.
Go ahead, Brian.
Yeah. Hey, when you find that they've changed their address, what do you do with it? Like if they've moved to, I don't know, the southern part of the state or out of state, for example, do you term the Medicaid or do you keep it open?
Oh, no, we are the only times that we are, like Michelle mentioned, there were the 3 reasons that we can close a case. So even if you have moved within the state, your case would not be closed, regardless of what the address situation is. Only if we can verify that you've moved out of state. And we have an entire process worked in about how we are changing addresses. We're not just simply taking this at face value. We're trying to reach out to customers to confirm those addresses before a change is made.
Oh, good. Okay. All right. But if they do, and you say there's just a small amount of people that are like changing addresses out of state.
Yeah. Between 6 to 8% is within state, and there's an additional 10% from those that we're changing that have actually moved out of state.
Okay. Thanks a lot.
Yep.
This is Sheila. I put a question in the chat, but I'm wondering, Marissa or Michelle, do you guys track or do you have any idea on how many members are leaving Medicaid each month since the PHE and related to the 3 criteria that you mentioned?
Yeah, Sheila, I'm not sure if you saw my message back in the chat. I did see that. Thank you for that question. We are currently working on tracking this information. I don't know, Maris, if you have more detail on that, but that is something that we're looking at in terms of outcomes and what's happening with our population right now. So I don't know if you have more to add, Murray?
Yeah, we don't have a necessary developed report for those 3 specific reasons. However, on an ad hoc basis, if there's a need, we can certainly pull that information up in any given month, how many closures we performed due to one of those three reasons. And if there is interest for that, I can certainly report on something like that maybe next month.
All right, thanks. I appreciate the answer.
Sure.
Okay. So just, oh, sorry, go ahead, Jesse.
I just have a question. In terms of the group, can you remind me, what are we planning to call, or how is the group being categorized that are closed because they didn't respond, or they didn't, because they weren't eligible, because we didn't have information about them, I guess. How is that group being categorized? So there's like a group that will be, their case will be moved to somewhere else, or like maybe to the marketplace, or they'll be continue to CHIP. But then there's this group that we just might not have any information about for a variety of reasons. And I'm just wondering how we're thinking about that group, or how they'll be labeled essentially.
Yeah, so I think, and I hope I'm getting to what you're asking, but I think what you're talking about specifically is once we start unwinding, right? And, we start, moving people to, where they appropriately will end up, right? And so we've got those individuals that will remain eligible, maybe move to a different program. And then we have the other group of individuals that will be sending over to the marketplace, like you stated. And then we have the individuals that I think you're talking about where it's for paperwork reasons, right? Meaning they failed to provide the requested verifications, or they failed to complete the review. Those would be the types of reasons that someone would end up in that group.
Okay.
Yeah.
Okay, that's helpful. I think one thing that, we're a ways out from being in that space, but I just want to be careful as a committee and just how we call them, like that fail to complete, because we know there's going to be a lot of something I've just been thinking about, there's going to be a lot of reasons why somebody may or may not respond. And if we use terms like failed, it definitely suggests that it's on the person versus like on the work in the system itself. And so I'm just putting that out there now. I've used that term in the past, and now I'm trying to be more mindful, because I am really concerned when the unwinding happens that category might sound like it's people's, who just decided not to respond. And of course there's going to be people like that, but there's also going to be things that, all the work that's going into place, it almost undermines that. And so I just want to, lift up, like there's a lot of work happening, a lot of things that people are working on behind the scenes to make that, to address those concerns. And so, it's not necessarily failure. There's something happening that we all want to fix together. So I know it's a little bit of a soapbox, but maybe we can revisit even just how we like categorize, or, in reports, things like that, so that because it's really easy to, for reporters or whoever's following this to then take that in a direction that I don't know, that's not the direction I want it to be considered, if that makes sense.
Yeah, no, I think that's a really great point, Jesse, and I've made a note of that, and I'm sure Jen is hearing this as well, and so I think we'll definitely be mindful of that.
Jesse, if I may, Michelle, I think you're kind of getting to a heart of a kind of an issue that I believe is somewhat minimized at this point.
Mm-hmm.
At this point, these are all speculations about how big that population is. I think if we were all trying to guess, I think we would all grossly underestimate how big that population indeed might be. So I think you're getting to a heart of a section of that population that's going to be, mailed out reviews and not respond back for various reasons, like you said.
That's nice. Yeah.
Yeah,
it's true. We don't know. That's kind of what's so frightening. We just don't know how big that group is at this point. So thanks.
Yeah, and again, I think just to add to what Marissa said too, I think that's part of our planning, right? So like going into these next steps, we are trying to think through all of those things that might occur and what we could do to be better prepared. So we're continually, you know, attending webinars that CMS is putting on, and you know, trying to learn from other states, you know, different strategies or different ways that we can, you know, be better or improve processes, just to try to help in any sort of way to minimize that, you know. And we're not going to be able to completely, you know, but I think if the longer this has kind of been extended, it's kind of been a blessing in disguise and has given us a little bit more time to be better prepared. So I think that's been a good thing for sure. And I think Maris would definitely agree with that as well.
Absolutely.
Yeah. So just like I was saying, next steps, you know, just again, continual planning, you know, updating materials. We're still preparing our eligibility worker training and working closely with DWS on this. And then just the data, you know, pulling data and developing our graphs that will be available for the dashboard that will be on our webpage. And we're hoping to put that out there when we, you know, roughly sometime around that 60-day notice that we get from CMS. So, okay. Oh, go ahead, Maris. Sorry.
The only thing I was going to add on the topic of pre-unwinding activities, we all understand that 60-day notice is not a very long enough time for the enormity of the change that we're going to have to implement. So in preparation for that, during the course of the past year, Michelle alluded to it several times, we have been meeting diligently to kind of put everything in place that we possibly can. Along those lines, we are preparing our systems to be ready for that change at a moment's notice. All those changes that are going to be required to happen once the PHE is declared are actually getting programmed into our system this month with a soft implementation timeline. So when we get the word go, we can start our training. We can show what the system will actually look like to our staff as we conduct that training. The training is getting finalized at this point. It'll be at least 3 sessions. Some of them will be in person, others will be online to prepare our staff for all these changes that are upcoming. One thing that concerns us greatly is that due to the fact that we have lost staff and we have had increased needs to hire additional staff, roughly about 1/3 of our population has never processed Medicaid in a pre-pandemic manner. That's a huge training issue and a concern for us, which we're trying to overcome as well. I think that covers the pre-unwinding activities, Michelle. Sorry.
Yeah, no, that was great. Thanks for adding that, Maris. And I think that's the end of the report. So I'll just, I guess, pause again and ask if anyone has any additional questions. Thank you.
Yeah, thanks. Terrific. Well, thanks for the update and just, you know, all the work and planning that I know you all are doing. And with that, I think we're up at the director's report. So Jen, it's over to you. And Sharon, just give us a time when you need to, well, cut Jen off with the update so we have time for the budget recommendations.
Thank you. And yes, Sharon, cut me off if we go too long here. So I'll try to keep it higher level. I did present some talking points just as a guide. In our preparation, there have been a few topics that were brought up for discussion and just presentation from me to you all. So hopefully we can update you on some of the work that's in place and if they'll fill you in on some important elements of what's happening. And then certainly if there are questions that you have, we're happy to answer those as well. So one of the first items we've been asked to present to you is update on our work around House Bill 413, which is Medicaid amendments, looking at an integrated model for our TAM population. And this is a work group has been established to do this work. We have been meeting every other Friday for now, goodness, several weeks, actually. I think we've had 4 meetings so far. And in the context of the meetings that have taken place so far, there's been incredible engagement on behalf of the working group, as well as additional members who are attending and contributing their thoughts, ideas, knowledge on this population. It's been really productive conversation. We've tried to stay member focused in our first meetings and really tried to understand the unique member needs that this population has. We've looked at Medicaid utilization data to try to understand what services are being utilized, who our population is from a utilization standpoint, and claims that have been billed to Medicaid. It's also important to appreciate and understand all of the other services that have been delivered to this group that facilitate care and help really support outcomes in the TAM population. And these could be things around housing, medication adherence, items around, whether that's court-ordered services and just coordination of care activities that our case management groups and other behavioral health teams and others are delivering to this population. And then the last element that we looked at was really understanding what an outcome of quality looks like. If we're going to design an integrated benefit that would deliver the best outcomes for this population, what are those outcomes? And how do we measure quality? And we had really a diverse set of responses and data capture in this area, spanning from like whether those are just standard HEDIS measures that are able to look at important factors that would influence this population, all the way down to really hearing the member voice and getting feedback on understanding like what matters to you, if that's staying housed or whether that's having to do with staying employed, things like that. So I thought it was a really productive conversation, and where we've agreed to go from this point, having at least this starting information about who our member is and what their needs are. We've moved into some sub work groups that are actually just being launched this afternoon. And we've decided, as we've really explored what various models could exist around integration, we wanted to generate some good discussion, really truly to understand what the best mode of delivery would be. Specifically, we're not married to one model across the entire state. There may be, one model that works better in our urban setting versus rural settings. It may be a part of the population or the whole population. We want to look at timeframes for implementation. We certainly, within these work groups, sub-work groups, would like to discuss what outcomes would be and important contractual elements, whether that's, high intensity case management and other services that would be needed. So we've broken up into 3 different groups. One is an RFI sub-work group that will explore the art of the possible with, if we're to design a model that would work for this population, what's an RFI looking like that could present this to us. Another model we would like to propose is a fee-for-service model. So taking our existing services today, but adding to those and adding case management services to our fee-for-service model as it exists today. And then our third model we want to look at is our ACO model. So our model we're employing at the UMIC plans, for example, this integrated delivery model, a very similar model, of course, with some unique contractual things that would really address the population needs here with our TAM population, could be introduced with the ACO model. So as I mentioned, we're just kicking off our sub-work group meeting later this afternoon. So we're excited to engage in conversations and see what will come out of this. What we're doing in these sub-working groups are we're going to do the work in these smaller meetings and then bring it back to our larger work group. So that is held every other Friday is how we're holding that meeting. And I believe our next meeting is August 5th, so next Friday. And if our meetings are productive enough and we're able to generate enough conversation, we'd like to actually bring our recommendations around RFI, fee-for-service, and the ACO model back into these working group meetings for larger discussion, evaluation, and vetting. So I think we're making really good progress. Our goal, of course, is to, as a working group, make recommendations for an integrated model. And the implementation could be anytime after July 1st of next year. So it would not be before July 1st, but anytime after July 1st is what we're aiming for. So do you have any questions? Okay. Great. Then I'll keep moving forward. I was asked to give an update on our PRISM system. You all know we've had really a large chunk of our Medicaid staff is giving a significant portion of their time to testing and training and developing all kinds of tools and resources necessary to ready our staff as well as our providers and stakeholders for our PRISM implementation system. As a reminder, this is a system-wide replacement for our MMIS and MMCS systems. It's been a more than 10-year project that will go live January 2nd of this year. So our teams are heavily involved in testing now. We are also very engaged in developing training materials, engaging our staff, bringing more folks into some training that does exist now, but just as important, really developing system training materials that will be used for our in-house staff, but also for our providers and our external stakeholders who use and engage with our PRISM tools. Of course, our training is very complementary of what our communication plan is. So part of our communication plan is to get the word out. And certainly it's important for every Medicaid provider and individual who's using our Medicaid services to be aware that, that our MMIS and MMCS systems are changing to a new PRISM system. We are launching a communication plan in September that's going to focus on sort of a statewide provider training that is PRISM focused. So it's going to give a broad overview of our PRISM system changes and how they might impact you, with greater detail coming in the next month. So our plans in October through December would be then to release more provider-specific training tools that will be a step-by-step training, whether those are live training sessions, taped sessions. Some will be just taped and on demand on our PRISM landing page, as well as resources and tools that are SOPs and different processes for individuals to understand and know how to submit claims, submit prior authorizations, or just get general information on what's changing and things they should be aware of. I do say over and over that January 2nd, if you log into any Medicaid system, it will look different. So it's important to recognize that this change is coming, and we certainly are doing a broad communication campaign to get the word out and let individuals know, but also engage them in what these changes look like and how they impact them. One last element I'll touch on is freeze information. So in order to support our data transfer from our existing systems to be lifted up and put into the new PRISM system, we will be doing a 3-week system freeze from December 13th to January 2nd. This will freeze the majority of our operations at that time. Things like pharmacy point of sale claims will certainly adjudicate and we'll be able to do that, but provider payments, various lookup functionalities that individuals are used to accessing and receiving, various things are going to be frozen and inaccessible really for providers and our staff as well. So there are a number of activities that we're involved in just to prepare for the freeze and help support providers and our members through this freeze period. So that is another whole communication strategy of its own, because just the freeze timeframe alone is going to bring about so much change that we want to know what's changing, how it's changing, and inform you of how we're going to manage those pieces. So we will bring that to you in the next meeting. It will already be August, and we'll be ready to introduce some more detailed information to you at that time, so you have some familiarity and visibility into what this looks like. Any questions on PRISM? Okay, I'm going to give a quick, I was asked to go through some policy updates as well, just to keep you in the loop on some of the changes that are occurring within our Medicaid program. And there are certain things that are timely I'd like to share with you now as they're happening August 1st. One important piece around dental services is an endodontic rate increase. This is something we've been working on for quite some time now, and really looking at the fact that individuals have challenges getting in to see endodontists for certain dental procedures, and our reimbursement was behind market, pretty far behind what the market and the costs for delivering the service were. We've been fortunate to be able to increase those rates, and they will be effective in our system August 1st. The rate information will be present in our August MIB that is in its final review right now and almost ready for publication. It will be present in our coverage and reimbursement lookup tool to see what those rate changes will be on August 1st. But they've already been put in the system. They'll show up in our coverage and reimbursement lookup tool August 1st. The next thing I've been asked to speak on is our Utah Transit Authority update and let you know how that project is going. This was a really large project. 25,000 individuals were mailed a hard card that would be a digital tap card instead of receiving a monthly paper card in the mail. They're now receiving hopefully a one-time tap card that they can just hold on to and use to access medically necessary services on Utah Transit Authority. We have successfully mailed out the cards. Certainly there's a number of return mail that we've had to define a process of how to manage that return mail and also manage those updated addresses. We've worked with DWS on this process as well in order to make sure we're getting that address capture in our system. I'll say from a member perspective that our HPRs were getting a large volume of calls when this program was initially launched. We did see people getting into the My Benefits tool, which is how members access and can request a UTA transit card for themselves. So we saw members actually getting in, going through the couple questions that are sort of the policy questions, asking to make sure they qualify for a UTA card, and they were engaging with the My Benefits tool, which was a really positive thing for us. We also had our HPRs fully trained to receive phone calls, stay on the line with members, and walk them through this so that they were able to successfully connect the dots and making sure that they were able to get a card. So right after this change was implemented just at the end of June to early July, certainly our call volumes went up quite a bit. They've tapered off and are actually back down close to our normal volumes. So our gentleman who runs the call center team said they were successfully able to triage, educate, work with staff members, and he feels that it went really well. We are developing a number of SOPs now that really look at how we manage our monthly reports, various elements even on how we're managing various things even around the return card process. So lots of great work being done right now with the team on just really finalizing that UTA transition. So we're excited that that was really a relatively smooth transition for our membership. And certainly we'll take any feedback you all have on that or any questions. I'm just going to keep plugging along here just so we have time for Sharon. We have several RFPs in the work. We have an NEMT RFP that is just about in its final phase of scoring right now. This is our Motive Care contract, which expires September 30th of this year. They have been our NEMT vendor for a number of years now, but this RFP has been up. It is in its final places of scoring, and we will be finalizing our work with the purchasing group in order to determine who our vendor will be going forward with NEMT services. We are also just getting ready. Yes, Jesse.
This is a question I just had about that contract. Is it so far along that is there still potential for stakeholder input? I'm just thinking of the issue I raised, what we've heard around like the 3-day need, the need to provide 3 days in advance and how that can really be burdensome for a lot of folks.
Good question. So 3-day advance notice, getting trips to the pharmacy, all these things that can be handled in contractual negotiations. So that's where we really wanted to handle it. The RFP and the elements within the scope of work have already been completed and the scoring's done. But we can certainly walk through those elements, and thank you for that feedback. It's important, important feedback, and those things are going to be discussed in the contractual negotiations. Okay, Stephanie.
Tiffany, you might be on mute.
Sorry. The other point that we heard was just about COVID. Like, so Medicaid members that test positive for COVID or their caregiver does, they're not allowed to use the medical. So anyway, that's like, how are they going to get? Anyway,
yeah, right now we're authorizing EMS. You know, Stephanie, we're still authorizing EMS to transport COVID positive individuals to appointments. So that's something we haven't changed. We've had EMS services, you know, and I think that information is on our sorry, I'm getting our COVID-19 Medicaid resource page. There is actually a whole an instruction document on using EMS services for transporting COVID positive individuals. But yeah, as a policy, that's something our current NEMT vendor is not able to do, is transport COVID positive individuals. So that's where, again, we're going to use our EMS vendors at this time. Okay.
Got it.
Yeah, good questions. Okay, couple other RFPs that are just about ready to be posted, I would say definitely within the next month, would be our managed care dental contract and our pharmacy point of sale RFP. So both of these are important RFPs to us, and they should be posted in the next few weeks or so. Couple things also, just touch on prior authorization updates. We've been doing some work evaluating prior authorization requests that come into us, and those items we have on prior auth that do come in at a higher volume but get a very high approval rate. So as we look at these two codes, personal care services, T1019, which defines personal care such as hygiene, grooming, assistance with ADLs and other services as defined underneath the scope of practice for a personal care aid. This has been on PA for a number of years, but it has a 97% approval rating when we look at those PA requests. So effective September 1st, we're going to remove the PA on T1019. These services, of course, are always eligible for post-payment review, but we will remove the pre-authorization. Likewise, on enteral formula, that has also a very high approval rate. And as we look at that, we are going to remove the PA requirements for the EPSDT population effective September 1st as well. So again, a kind of ongoing evaluation we do of our prior authorization process, making sure the prior auth is there for good, solid clinical reasons, and that, there's a good blend. If we're seeing approvals over and over and over, then we want to question, is there still value in having this prior auth here? Or do we want to evaluate taking it off? And as we put this through our policy team and evaluated it, we determined to remove PA on these two items. The last item we'd like to announce is a really exciting change for our TAM population. And this is a waiver amendment that was submitted some time ago as well as part of our 11, I believe, oh, Joe, now I'm questioning. I believe it's our 1115 waiver as well. It is. But our housing related support services for the TAM population. So there's quite a bit of text here, and what I included to be comprehensive for you, and we're going to share this document with you as well as part of our meeting materials, was our MIB article. Okay, so this really defines and describes the services, but our housing related support services does provide important assistance. It does not pay for housing. It pays for housing assistance to the TAM population. These items are defined below. Can be things like supporting living services, coordination services, coordinating mental health services, substance abuse services. There's tenancy support services. So helping with tenant screening, looking at barriers around individuals who are having challenges, having successful tenancy, helping individuals with applications, or even for education regarding their rights as a renter, whether that's for the individual member or whether that's for the landlord themselves, and also eviction reduction services. There's also really important work around community transition services as well that looks specifically at the fees and the costs tied around housing related supports. So Joe and his team have been doing a lot of work on this directly with providers to educate them on these services and to let them know about this availability and how they're going to be billed and what these actually mean. It's important policy to really augment the services that are available for the TAM population. So Joe, I don't know if there's anything else you want to add to the presentation here.
Yeah, maybe just a quick plug where you mentioned we've been doing targeted outreach to the entities that we know are working with the TAM population that are already engaged in this work, just obviously absent of Medicaid support. So if you are one of these providers and you haven't heard from us, please let us know. The email address at the bottom of the screen is active, the LTSS_housing@utah.gov. Please feel free to reach out to us. We want to assist with anything that we can do to help with your Medicaid enrollment, particularly where we know a lot of providers haven't necessarily worked with Medicaid directly. We do have support staff that can assist with your enrollment and link you with resources for how to submit Medicaid claims. But yes, please reach out to us if you haven't heard from us already.
Thank you, Joe. So Stephanie did ask a question, Joe. Are any TAM members able to get this help? Or what is the risk-based criteria? So I'm just going to read what's here, Stephanie. These services are available to Medicaid members aged 19 through 64 who are members of TAM and meet the criteria. Joe, could you talk about what those criteria are, or could you maybe share them in the chat?
It is a little bit lengthy. I can work on that, but essentially it's the same criteria that is used to determine TAM eligibility in the first place. It's a little bit awkward where we are required by CMS to kind of perform a confirmation assessment on the same risk factors of why somebody qualified for TAM in the first place. So it really doesn't add anything where there isn't additional criteria. It's just the verification before the receipt of the housing related services and supports.
And we can certainly provide more information, Stephanie. We can email some of that to you as well.
Yes, we're in the process of publishing a web page, which will be a landing page for all providers and members, which will include our provider manual and other resources. The manual as well will include the same risk factors and targeting criteria as well.
Okay, and that will be on August 1st. Jeannie will be the go live date for this. Okay, thank you. So Sharon, over to you.
Yes, so in the last 4 minutes, this shouldn't take very long. So I am showing on the screen, and I will go through and read these aloud for the people on the phone. And I will also be sending this document out as well as Jen's presentation to everybody to the MAC distribution list. So you will be receiving this. To note that only 9 members voted, so just slightly over half of the 17. So I might keep this open like one more day until tomorrow, but then we kind of have to close it. In the past, not many other committee members vote after today. So I'm not expecting more votes, but just to know, we had 9. So this document here that I am showing is the results with the score. So the committee members voted their priority from 1 to 15, 1 being their highest priority. So lowest score is actually the top recommendation for these for the 15 budget recommendations here from the presentations in June. So I will just start from the top and go down. So with the lowest score of 42, that is the Medicaid pregnancy and postpartum coverage. The second lowest score is the coverage for all Utah kids. Third is the mental health and developmental disabilities. Fourth is the DSPD family caregiver compensation. Fifth is the Medicaid rate for home care. 6 is the community health workers. 7 is expanding family planning services. 8 is ensuring access to complex rehab technology for Medicaid beneficiaries with disabilities. 9 is the non-invasive prenatal screening. 10 is the durable medical equipment rates. 11 is the LTAX reimbursement. And then with a tie score here for the 12th score, we have the intermediate care facilities for the intellectually disabled quality incentive funding and the assisted living new choice waiver rate increase. So that brings us to 13 is the Cologuard and 14 is the ePass program. So again, those are the results of the votes from the committee members. Any questions? And again, we will be sending this out.
Sharon, do you know how many, is that lower than usual, the 9?
I would have to go back and look. It is pretty low though. I mean, you know, there's always, some people might be out of town, that sort of thing. So 9 is pretty low out of 17, right? We've got 17 voting members. So.
Okay. Thanks.
Mm-hmm. You're welcome. I'll turn it over to you, Jesse.
Thanks, Sharon. Well, with that, I know there's a lot of information that's going to be going out after this meeting. Jen, thanks for that overview, that really comprehensive overview in the write-up for the director's report too. And yeah, I think we covered a lot. Thank you all for the information you shared, and we'll see you at the August meeting, which will be back to our regularly scheduled 3rd week of August. So thanks everybody again for adjusting for this meeting, and we'll see you in August. Again, have a great rest of your summer, everybody. Bye.
Bye.